Good afternoon. This is Gina Hurst. I'm happy to be speaking with you today about rapid sequence induction for intubation and our plan for utilization of this procedure within the medical intensive care unit. So this is going on throughout the hospital on a regular basis. Rapid sequence induction and intubation is really the use of paralytics in conjunction with our sedative medication for intubation. The purpose of rapid sequence induction for intubation is really to minimize the chance of pulmonary aspiration, to protect the airway with an endotracheal tube as quickly as possible after induction, and hopefully with the use of paralytics, as well as minimizing any pre-oxygenation with bag valve mask, we will reduce the chance of passive or active regurgitation by preventing coughing, straining, or vomiting with airway manipulation. Additionally, we can limit things like transient increases in intracranial pressure for our patients that are suffering with high ICP in the medical ICU. For intubation with rapid sequence induction, there are 7 Ps that we often talk about, and these are all the typical preparation and treatments that we provide our patients typically when we intubate in the medical ICU, except for the one factor of inducing paralysis for our patient. So we typically are familiar with the preparation, pre-oxygenation, and pre-treatment medications that are required for our patient. We obviously will make sure that they're appropriately positioned, as well as proof that their endotracheal tube is in an appropriate place. We are masters of post-intubation management to ensure that our patient is well set up on the ventilator. One thing that we don't typically practice in our medical intensive care unit is paralysis outside of the presence of anesthesia. And this has to do with policies that had been in the process of being developed over the course of the past several years, and luckily have developed in such a way that we're able to utilize these medications with appropriate credentialing. The agents that we use for rapid sequence induction, both pre-treatment and induction, are not going to change, but the addition of a paralytic is the wonderful thing that we have to add to our armamentarium. So pre-treatment is likely going to be the same. Most of us use fentanyl. Some people may use lidocaine or other medications for pre-treatment for rapid sequence induction. Your sedative medicine, etomidate or Versed, will also be the same. You may also consider the use of ketamine for the appropriate patient. And then your paralytic will generally be a choice between succinylcholine or rocuronium, with the reversal agent for rocuronium, sugammadex, being available. We're specifically going to focus on rocuronium as our medication of choice, and we'll talk about that a little bit more later. So if I'm intubating a patient, what do I need at the bedside? You are all familiar with our yellow tackle box, and pretty much everything that we need at the bedside for routine intubation is going to be present in that tackle box. There's some of the things that we need are, just in the room, and other things are going to be within the pod of the medical intensive care unit. So your bedside needs are going to include your cuffed endotracheal tube. Within the tackle box, we have our oral airway, nasal trumpets, there's tongue blades, just adjuncts that will help you insert your endotracheal tube. There should be a functioning laryngoscope, handles and blades. And then in the room, there should be a bag valve mask attached to an oxygen source, a suction device with a wall trap. And generally, we should be bringing airway junks near or inside the room for backups if our first attempt is not functioning to our best, within our best hopes. So our airway adjuncts may include your glide scope, your bougie, and then failed intubation airway equipment is also important to have on hand, like your LMA or in some cases, a cricothyrotomy kit. In addition, their bedside needs include their monitoring systems, a reliable IV line, and these will be initiated by the nurse that is caring for the patient at bedside. Medications that will be required are the pre-treatment drugs, induction agents, paralytic, and post-intubation sedatives. And we'll speak more specifically about these medications again as this talk continues. We should also have things available like end-tidal capnography, as well as our mechanical ventilator when we're initiating intubation, so we can set our patient up for success once our airway has been obtained. In preparation, or when we're thinking about intubating a patient, we should always move through emergency checklist or a methodical approach. We need to make sure our patient is being prepared, our equipment is being prepared, our team is ready, and also prepare for difficulty. So in this time that we're preparing for rapid sequence induction for intubation, we want to pre-oxygenate our patient either with a non-rebreather, or if they're requiring higher oxygen than a non-rebreather is able to supply, then high flow nasal cannula or BiPAP. While the patient is awake and prior to receiving any sedatives, we want to ensure that the patient's position is optimal for intubation. And if they're very obese and we need to ramp the patient, this should be something that we should be conscientious of prior to intubating. If we can optimize the patient's condition prior to intubation, this is another consideration that we might have. Is there, a way that I can ensure that I have, pressors nearby, or I have fluids, to tank them up with so they don't drop their pressure. And then considering how will I be able to maintain this sedation after I intubate the patient. Preparing our equipment, this is similar to what we discussed on our last slide, is do I have all of the appropriate monitoring devices, and have I checked my equipment? Do I have all of the medicines that I need? And then once we're all in the room with my patient, pre-oxygenating with all of my equipment, then we can assign roles if those already have not been clarified within the room. And one of the questions that we often ask as we're preparing the team is, how do we contact further help? We have an urgent airway team within this institution, and on the last slide, there'll be their contact information if needed. And then fourthly, we want to prepare for difficulty. And I think this is the most important step. We are pretty good at preparing our patient. Our teams in the medical ICU generally know who's doing what, and our equipment is kind of pre-packaged. So preparing for difficulty is a little bit more of the cognitive step. Number one question to ask is, if I run into difficulty, could I just wake the patient up? And this is the role that Sugammadex may have. However, oftentimes when we run into a point of, if the airway is difficult, could we wake the patient up? They've already been sedated with etomidate or Versed, and the airway patency has been taken away with the sedatives alone. So this may not be, the answer may not be yes to this. If the intubation is difficult, do I have plans to maintain oxygenation? Do I have that equipment? Do I have that LMA? Do I have that bougie ready for me? And are there any specific complications that I can foresee with the patient, either based on their body habitus or based on their previous medical conditions that I'm aware of at the time of intubation? So as we are using rapid sequence induction, it's important, whether you're using paralysis or not, to go through this flow sheet. But it's also important, as we consider paralyzing these patients, is there any concern that I have that the paralytic may play a role in this difficulty? So speaking more on the paralytic, we are going to favor Rocuronium for intubation within the medical intensive care unit, and we'll talk a little bit about how we came to that decision. So Rocuronium's mechanism of action, it's a non-depolarizing neuromuscular blocking agent. It's competing for cholinergic receptors at the motor end plate, and the normal dosage for this medicine is 0.6 to 1.2 milligrams per kilo. It's an IV medicine, and it will be supplied in one of two ways. It can be supplied in a pre-filled syringe, or on this next side, you'll see it could be provided in a vial. Within our institution, the Pyxis is going to have Rocuronium in vials. The time to paralysis of Rocuronium is somewhere between 45 and 60 seconds for most patients. Now, the caveat to that is the lower dose you use, the longer time it takes to achieve paralysis. So if you're starting on the 0.6 milligram per kilo dosing of per actual body weight, it may take 60 seconds or it may take 90 seconds to achieve paralysis in your patient. We generally recommend the use of 1 milligram per kilo of actual body weight for initiation of paralysis, as this likely will put you in that 45 to 60 second range of induction. The duration of paralysis that you can expect with rocuronium is anywhere between 30 and 40 minutes, and maybe longer in specific cases. So the important thing, knowing that our duration of paralysis is longer, sedation drips at the time of intubation are going to be incredibly important. So initiating your propofol infusion or your Versed infusion at the time of intubation is going to be appropriate so you don't have a paralyzed patient that is not effectively sedated. In addition to this, it's important to know which of our patients may require prolonged sedation. So if we can minimize the amount of sedation that our patient is receiving, that would be great. However, there are times where we have to be able to expect this. So prolonged time of duration can occur in patients with liver failure or geriatric patients. And the studies have identified geriatric patients, and I wish you could see my finger quotes for all of us, as being over 65, which is not terribly old for the majority of our medical intensive care unit patients. But those that were greater than 65 generally tended to have a longer duration of paralysis, and oftentimes recorded up to 90 minutes post-use of rocuronium. And a similar thing can occur in patients that have liver dysfunction. So these medicines can be used. There's no contraindication in this patient population, just to have the knowledge that our patients may be paralyzed for a longer time than we would expect, such that sedation should be available. One thing to note for our obese patients, we do use their actual body weight for dosing. So just be conscientious. Some of our super obese patients may need 2 vials of rocuronium brought to the room rather than just 1. Are there contraindications for rocuronium? Not many. Really, the only contraindication for rocuronium is history of anaphylaxis to neuromuscular blocking agents. And this was one of the main reasons that we chose rocuronium as the medicine that we would store in the Pyxis. We'll talk about succinylcholine. It will be an option, but it won't be the readily available option within the medical intensive care unit. Sugammadex is the reversal agent for rocuronium. Now, this medicine is really great when you have a ROC or VEC infusion in the operating room, you've paralyzed a patient for general anesthesia, and you want to slowly remove their paralysis. You're following a train of 4. This medicine is great for them because it binds to the paralytic that they've given, and over the course of time reduces the availability of the ROC or VEC to bind at the neuromuscular junction. So in effect, it will reverse the neuromuscular blockade. However, in the setting of an urgent reversal of paralysis, you need to use a pretty high dose. So the dosage for immediate clinical reversal is going to be 16 milligrams per kilo IV of actual body weight. And it doesn't happen immediately. It can take 3 minutes or sometimes even longer for the Sugammadex to kick in. So while this medication is, a potential reversal agent for our patient and may be beneficial in some clinical scenarios, be mindful that it takes a high dose of this medicine, as well as it takes a little bit of time for this to work. And for those of you that have had a difficult airway in the past, 3 minutes can feel like an eternity. In addition, this is not going to be routinely stocked in the Pyxis, so you will have to contact pharmacy if this medicine is something that you hope to achieve. So it may be longer than a couple minutes in order to utilize this medicine. Now, succinylcholine, this is a medication that is often used within the emergency department as well as the operating room for rapid sequence induction. This medication is a depolarizing neuromuscular blockade. The dosage is 1 to 2 milligrams per kilo IV, and the time to paralysis is going to be a little quicker for succinylcholine than ROC, usually that 30 to 45 second range. And then the duration of paralysis is much shorter, usually about 5 minutes of time for paralysis. However, the contraindications for succinylcholine are much higher. There's, the typical, you're allergic to Sucks, don't use it. If you've had a history of malignant hyperthermia, or you have a history of things like skeletal muscle myopathies. But more importantly is the acute phase of injury. So those that have suffered significant trauma, burns, they have new denervation of skeletal muscle from a stroke or upper motor neuron injury. these individuals can develop severe hyperkalemia, sometimes resulting in cardiac arrest within the first week following injury. And so, while our patient population, some may fall into this, not all of them, but having a medication available in the Pyxis that doesn't have as long of a list of contraindications, we felt would be the most beneficial for our patients. Now, again, if you felt like a short duration of paralytic would be more beneficial to your patient, for perhaps they have significant acid-base disturbance and you don't want them to be paralyzed for 30 or 40 minutes, you really want them to be breathing spontaneously, you can contact the pharmacy and request succinylcholine as your induction aid or as your paralytic agent of choice. It's just not the one that's going to be routinely stored in the Pyxis, so be conscientious of that. So in real life, what does this look like? There are physician requirements, nursing requirements, and pharmacy expectations as well. As far as the faculty are concerned, all of you are credentialed in intubation. This is something that you're doing on a daily basis, if not more. There is education, obviously, to ensure that we're all, receiving the same information across the board. And this is what we're doing today, which is this rapid sequence induction refresher. And then if there are those of you that are interested in gaining more skills for difficult airway management, there's a workshop that can be offered for the staff. We generally offer it to our fellows. Please let me know if you're interested in this. We can either include you with fellow education. If there's 1 or 2 individuals, we can just tack you onto a workshop. If there's a lot of people that are interested, we could create a difficult airway workshop for the faculty as well, just so you feel more confident in rescuing an airway if you were to run into issues with paralytics. One thing that's important to note is paralytics will be drawn up and administered by faculty, and this is to keep within the policies that have been written by anesthesia. So very specific policies were written in written in 2019, but revised in 2020, and that those policies require that a physician, and specifically a faculty member, is delivering paralytics when they're, unless it's an emergent situation. Fellows will be participating in rapid sequence induction. They will be supervised by faculty anytime they want to use a paralytic. Fellows should be supervised when they're intubating in general. If for some reason it's an emergent situation and they can't contact a physician in time, they should just be using their standard sedation methods without the use of paralytic. And if they need paralysis, or they determine that a paralysis is indicated and the MICU faculty is not available, then they should be contacting anesthesia for paralysis, as they typically do currently. Now, nursing requirements, there are nursing requirements that are laid out within the policy as well. Our nurses meet this. They have ACLS certification. They are appropriately able to monitor patients during sedation and intubation. The familiarity with RSI meds is an effort that our nursing educators have worked to provide our nurses with. And then their specific role is going to be obtaining the medication from the Pyxis to provide to the attending physician. So the typical acquisition of etomidate and fentanyl or whatever other medicines you're using for your induction agents will be obtained by the nurse along with the paralytic from the Pyxis. Paralytics will again be administered by the faculty, except in certain situations. And the situation would be an emergent intubation where there is not a 2-physician team. So if there's, I would imagine this happening more so in pods, in the green pod, where there's an overnight faculty, but there's not a fellow. And in this case, the intubator would be the faculty member, so the nurse would be administering the medications. Pharmacy's involvement is particularly stocking the Pyxis with Rocuronium. There should be 4 vials of Rocuronium in each Pyxis throughout the medical ICU pods. There was a question previously about whether or not this needed to be refrigerated. This will last 28 days without refrigeration. So pharmacy is planning on ensuring that there'll be enough Rocuronium for typical management of our patients in the medical ICU, as well as that the Rocuronium will be appropriately utilized prior to moving into other departments that may use it more quickly. As I mentioned before, Succinylcholine or Sugammadex are available by request. And this is, the routine way you get medicines. You put the order in, and pharmacy will have to bring it up from central pharmacy or from the critical care pharmacy. Now, another thing that's going to be important for us is how can we effectively document our patient's intubation. The documentation of our patient's intubation should be akin to how our documentation is all the time. We have a procedure note that we write. The one thing that's important to include in our procedure note, and in fact required for any intubation, is documentation of their pre-sedation and analgesia ASA class and Mallampati score. So ASA class, I think most of us can identify in our patients. The question is, do we always have a Mallampati score? We don't always have a Mallampati score in our patient if there's an emergent intubation, but luckily there's a little tab that's marked E for emergency. So if for some reason your patient's crashing and you haven't had the time to do that airway assessment prior to intubation, you can click E. If for some reason you know nothing about the patient and you're intubating them without any awareness of their ASA class, you also could click E for emergency in your ASA and Mallampati scoring tab. Now, intra-procedure monitoring is another important part of the policy that's written. We meet these criteria by the nursing documentation that's completed during the code summary. This is another way to visualize this, which is much more cumbersome, but all of the information of attempts, any bag, BVM needed between attempts, vital signs throughout are all documented in order to ensure that we're abiding by the policies that the health system has in place. When you do appropriately document your patient's note, you will have their pre-sedation ASA class and Mallampati present in your note. Please make sure this is there before you sign the remainder of your procedure note. It usually gets pulled in as long as there's one recorded, but this is just important for us to maintain appropriate documentation of intubation. Again, whether or not you're using paralytic, this should be there, but definitely if you are using paralytic, we should ensure that this is well documented. And this is just what a picture of your note will look like, but most of you all have seen that. So what our sequence would look like then is we decide our patient needs to be intubated. This is on the left-hand side of the screen. We are going to be gathering supplies and medications for intubation. Airway supplies and adjuncts are going to be checked by the intubating physician, and the nurse is going to obtain sedation and paralytic from the pyxis. Now, the nurse is going to be giving the sedative medications. However, the physician with a two-physician team is going to be administering the paralytic. If there's a single physician intubation, then the nurse is going to be administering the paralytic. Again, this is to keep in line with the policy that has been set forth by anesthesia and the institution of critical care. Once RSI is initiated, then we have two pathways to move down, either A, successful intubation, or in some situations, we may have a failed airway. This is the time when you may consider the option of Sugammadex. In this flow sheet, it says that they may have it from the pyxis. At this current time, it won't be stocked in the pyxis. It will be in central pharmacy. However, that may change. If there's concern for airway failure, use your bedside airway adjuncts. Bag valve mask your patient as you normally would. Insert an LMA when it's appropriate for the patient. Most patients that will be appropriate, we have LMAs within the medical intensive care unit, and we'll make sure that those are more easily accessible and centrally located for our intubations. Obviously, if you're having difficulty with your airway, contact the urgent airway team. This is 161111. This should bring anesthesia and surgery to bedside. If there's no response from anesthesia, you can call the emergency department. And this is just following the urgent airway algorithm that you could Google on the Henry Ford intraweb. 168150 is the emergency department number if you need airway assistance and are unable to get a hold of anesthesia. And then if you think that the reversal of paralytics is going to be useful, consider contacting central pharmacy or your critical care pharmacist for the medication to reverse your paralytic. Again, contacting your urgent airway team should outweigh the use of paralytic reversal consistently as your patients are sedated, and so their airway patency and difficulty with oxygenation or ventilation will likely still be present even with reversal of paralytic. Grateful for your time. Feel free to email me with any questions. It's ghurst1@hfhs.org. And if there's any questions that you have that you don't want to email me, feel free to text or stop me in the hallway. Have a great afternoon.